I'm going to kick off the session 3 with a great talk by Dr. Mimmie Kwong, speaking about the underutilization of palliative care for patients with advanced peripheral arterial disease.
Hello, my name is Mimmie Kwong, and I'm a vascular surgeon at UC Davis. I will be presenting my work studying palliative care utilization in our patients with advanced peripheral arterial disease. I have no relevant disclosures. Advanced peripheral arterial disease is associated with an incredibly high mortality rate, with 15 to 40% of patients dying within 1 year of their diagnosis of chronic limb-threatening ischemia. This mortality is even higher in the subset of the population that requires an amputation. These patients experience mortality as high as 50% at 1 year after an above-knee amputation. Comparatively, mortality is similar or even lower in other conditions such as stage 4 colon cancer, heart failure, and COPD with recent hospital admission, which are considered advanced conditions in which end-of-life care should be considered. Published data suggests that surgical patients are less likely to receive palliative care consultations. There are many reasons theorized for this, ranging from poor awareness or training in the provision of palliative care, to difficulty reconciling the conflict between offering an aggressive intervention such as surgery while also recognizing the poor prognosis associated with a patient's condition. Unfortunately, there is limited published data on palliative care utilization specifically in the vascular surgery patient population, despite the significant comorbidities and high morbidity and mortality experienced by our patients. 2 published studies have specifically addressed palliative care utilization in the vascular population. Wilson and colleagues performed a single-center study at their academic medical center that looked at 111 patients that died on the vascular surgery service. Of these, only 14% had advanced directives and only 25% received palliative care prior to their death at a median of 10 hours. However, this paper studied a heterogeneous population that included a variety of vascular diagnoses. Demestro and colleagues from Ontario published a study that looked specifically at patients with PAD or diabetes that died. As compared to non-amputees, amputees with peripheral arterial disease or diabetes were less likely to have a palliative care evaluation both on the inpatient and outpatient setting. Only 13.4% of amputees that died had a palliative care consultation, and these amputees had a much higher cost of care. Home palliative care actually reduced hospital days and decreased likelihood of in-hospital death in this study. However, many questions remain. In the United States, palliative care programs are not well established, and access can vary from hospital to hospital. In the US, how well do we utilize palliative care in PAD patients, especially those with the most advanced disease who are undergoing amputation? Where can we be doing better? We therefore sought to understand palliative care utilization rates and patterns at our academic medical center in California, specifically in a patient population with advanced peripheral arterial disease requiring below-knee amputation. To do this, we performed a retrospective review of all patients who underwent a below-knee amputation over a 5-year period. Patient demographics, comorbid conditions, medication use, intraoperative factors, and perioperative outcomes were recorded. We evaluated if and when palliative care consultations occurred. We also identified which patients died at 1 year, and statistical analysis was performed using this data program. Out of 111 patients that underwent a below-knee amputation for PAD indications, the mean age was 62.3 years. 68.5% were males. Half of the patients had chronic kidney disease and half had coronary artery disease. 70% had diabetes. 30% of patients were on Plavix, and over a quarter were on anticoagulation. Over 3/4 of patients lived at home prior to their amputation. Looking at outcomes, 1/3 of patients experienced some type of wound complication, including infection, hematoma, and wound breakdown. 30% were readmitted within 30 days, though not always for issues related to their amputation. 1/5 returned to the operating room within 30 days of their operation, though again this was not always due to their amputation. 5.6% died within 30 days of their operation. Looking specifically at the patients that died within 30 days of their operation, out of the 6, 2 received palliative care consultations. None of these consultations occurred prior to or at the time of their amputation. For both, their consultations occurred much closer to the time of death than to the time of their amputation. Looking at all subjects, out of 111, 3 patients underwent palliative care evaluation around the time of their amputation or prior to it. 2 were to provide assistance with surgical decision-making. 1 patient was already being followed by palliative care due to their malignancy. 73 subjects had follow-up data available at 1 year, and out of these patients, 22% of them had died by 1 year follow-up. Death occurred at a median of 70 days after amputation. 6 total subjects, or 38%, had palliative care evaluation at some time prior to their death. This includes the 3 that had palliative care evaluation at the time of their amputation. Looking at the timing of the consult, these consultations occurred at a median of 26 days after their amputation and at a median of 9 days prior to death. The most common cause for death was cardiac, followed by pulmonary and malignancy, and a small minority had end-stage renal disease, infection, or other causes. We compared those that died to those that did not to see if we could better identify which patients would benefit from a palliative care consultation. We found that those with kidney disease, as well as those that required Plavix or anticoagulation preoperatively, perhaps as a marker of advanced cardiac disease, experienced a higher mortality. In summary, 22% of our patients underwent a below-knee amputation died within 1 year. This is similar to rates published in the literature. Amongst these patients with advanced peripheral arterial disease, there is significant underutilization of palliative care consultations, with only 2.7% of patients receiving a consultation at the time of their amputation, and none of the patients that died within 30 days receiving a consultation prior to their amputation. Only 38% of patients had a palliative care consultation at some point prior to their death. This is a significant missed opportunity for us to provide truly comprehensive vascular care to our patients. And this is important because palliative care consultations have been shown to be very effective. They decrease hospital mortality and ICU admissions. They reduce overall cost of care, reduce patient symptoms, and improve their quality of life. And most importantly, palliative care evaluation helps ensure that medical care that we are providing aligns with the patient's end-of-life goals. In future studies, we hope to work toward improving palliative care evaluations both at our medical center and on a larger national scale. This will require a better understanding of palliative care utilization patterns nationally, a better means of identifying which patients with advanced peripheral arterials would benefit from palliative care consultation, and a plan to integrate palliative evaluations into the comprehensive vascular care that we do provide. This is some of the work that I've cited, and I wanted to take this opportunity to thank the group that we have here at UC Davis for all of their assistance in making this research happen, and the program committee at VESS for the honor of presenting at the 2021 VESS Winter Program. Thank you very much, and I'm happy to take any questions at this point.
Thank you so much, Dr. Kwong. That's an insightful study, and I think with some important information. This paper is open for discussion, so everybody who's watching on the live stream, please let your questions roll in. I'm going to kick it off with the first question from Dr. Rajani. Thank you for the great talk on this important subject. What specific changes have you implemented locally following your study?
So there's actually a couple directions I'm hoping to take this. So one is we've started utilizing our palliative care specialist more, including asking for them to come to our outpatient clinic. It's not, unfortunately, set up very well for them to do so, but we're having them come to our clinic to see some of our more high-risk patients, both for peripheral arterial disease as well as for other issues. And so that's kind of on a local level. I'd love to be able to make that a more formalized relationship. And so we are definitely working on that. I'm looking into local grants to be able to help me make that happen. And then on a kind of a grander scale, I'm hoping to really gain that, to build that data, build that information to better understand truly how poorly utilized palliative care is. I suspect poorly utilized palliative care is on a larger scale. We have a few kind of local studies. We have our study from our Canadian colleagues, and then we can gather small bits of information from studies that have been published on surgery patients in general in the VA, as well as in in certain hospitals, but we really don't know what we're doing on a national scale for our patients. And so I'm hoping to actually utilize a large database such as the Medicare data to better understand what we're doing at the end of life for our peripheral arterial disease patients.
You know, the second half of your study sort of focused on predicting who was going to die and who might benefit from palliative care referrals. But I wonder, you know, with major amputation really being an end-stage version of vascular disease, if all these patients may benefit from a palliative care referral prior to amputation.
Absolutely. I actually definitely, you know, the part of the issue is with palliative care utilization is people always say it's very hard to say which patients live and which ones are going to die. But we've in the palliative care literature, one of the things that should prompt a palliative care evaluation is the question, well, would you be surprised if this patient is dead in a year? And, unfortunately, for a lot of our patients, the answer to that is no, I would not be surprised. And so for all those patients, really, they should get a palliative care evaluation, not just because we want to establish their goals of care, but really to help them start planning their end of life, not just for us, but for our patients. And I think it would be very important for us to implement such a program. But I think it has to be data driven, and gathering some of that data will be an important first step.
To dovetail on that question here in the chat from Callie Johnson from USC, any thoughts on why palliative care is so underutilized in vascular surgery? I mean, why are we not taking advantage of these resources?
I think definitely a part of it is the nature of what we take care of. So a lot of our patients are very sick, and they come with very serious problems and complex medical issues. And to some degree, it's because of that, our job is to see if it's possible for us to make our patients better, to prolong their life, to give them the best quality of life that we can for what remains of their life. And so I think that conflict with what is the nature of the disease that we take care of, with the fact that we are surgeons and proceduralists who want to be able to provide a solution to the patients, makes it uniquely hard for our specialty. I think that there's very little research that's been done. Whereas if you look at things like heart failure, COPD, the oncology literature, and even within surgery in the ICU setting, there's a lot more that's been done that shows that there's a benefit. I think if we can find a way to show that there's a benefit, or at least programs that have been helpful to patients, whether that's reducing their hospital days, reducing their chances of dying in the hospital, aligning their goals of care, having them be around family when they die, these things or even reducing cost of care, if we can show these benefits, I think it'll be much more widely adopted, and it'll be much easier to implement these programs on a local setting.
Question coming in, to clarifying question, appreciate the focus on our very sick patient population, but can you clarify, did you only look at BKA versus AKA as well?
I did only just look at our BKA patients, not for any particular reason. I just, what it really was I actually started looking at our BKA patients for another separate reason. And, if by complete happenstance, I have a very close colleague who's actually a palliative care specialist. And we were discussing how high the mortality rates were among these patients that I was following kind of in this longitudinal study. And the more we looked into, the more kind of I was shocked by these findings. And so I actually ended up going back through the data from my BKA patients to see what actually happened to them and who got palliative care consultations. And so that's actually how this ended up, not because I specifically wanted to look at the BKA only population. I think it would definitely be helpful to look at the AKA patients as well as our open aneurysm patients and these other high risk surgery populations.
Yeah, it may get some more power there too if you can increase your N, because it looks like your number of palliative care consults was fairly low. Last question here before we have to transition to the next talk. We're getting a lot of action here on the chat, so maybe some people can sort of continue their conversations offline. But do you differentiate end of life care from palliative care when you're talking about this with the family and the patients, and then also their medical practitioners from other specialties?
So I think it is important to differentiate between some things like a post or an advanced directive, which is more just writing down kind of this is what I want in different situations, than more kind of general end of life care. What do you value? Where do you want to be when you die? Things like those are a lot harder to just put on a piece of paper. And so I think what our palliative care specialists here do a very good job of is discussing those things, and not just, do you want a feeding tube? Do you want to be intubated? Do you want chest compressions? I think both aspects, both sides of that coin are very important, and involving our palliative care specialists to have that discussion is very helpful. And I think as surgeons, we definitely underutilize it compared to our medical colleagues. And I see our MICU medicine colleagues do it a lot more. And that's actually been seen in the literature as well. And so definitely something that we all need to work on. And hopefully here locally, we'll start making that a reality.
Great. Well, thank you so much for a great talk, and congratulations on your work. I'm going to turn it over to Dr. Kang for the next introduction.